Welcome to Roadmap to Residency. Hello everyone, I am Abhiraz. Welcome to our Club 250 Matchmaker sessions. We will be running through a question with you guys to help you on your journey to a 250. So whenever you encounter a USMLE style question, you need to read the last line first. This will give you an idea about what to catch up in the whole long question stem. So here we have, which of the following mechanism is primarily responsible for the elevated blood glucose levels in this patient with diabetes mellitus? So now we understand that this question is asking us about the pathophysiology behind the patient's diabetes mellitus. But for that, we need to know what sort of or what type of diabetes mellitus the patient has. So here we have a 45-year-old female who presents to her primary care physician with complaints of increased thirst, frequent urination, and unintentional weight loss over the past few months. On examination, she appears generally well with no signs of acute distress. Her blood pressure is 30/80, heart rate is 80 BPM, and BMI is 28. Lab tests revealed elevated fasting blood glucose levels, HbA1c of 7.8%, and normal lipid profiles. Which of the following mechanism is primarily responsible for the elevated blood glucose levels in this patient with diabetes mellitus? Now, the patient has all the typical features of diabetes mellitus. She has HbA1c of more than 6.5%. She has increased thirst, polyuria, and polydipsia. Okay, the person also has weight loss, and our lab results is also showing increased fasting blood glucose levels, which are all typical features of diabetes mellitus. But now we need to determine is it a type 1 diabetes mellitus or is it a type 2 diabetes mellitus. But here we can see that there is a lack of information about the autoimmunity or something, or if it is autoimmune, it should have started in a very young age or so. So this is typically a case of type 2 diabetes mellitus. So what is the pathophysiology behind the type 2 diabetes mellitus? So decreased hepatic glucose production, increased insulin sensitivity in the peripheral tissues, impaired insulin secretion by pancreatic beta cells, reduced glucose uptake by skeletal muscle, or upregulation of adipose tissue lipolysis. Just pause the video and think, what do you think is the answer? So this explanation is D. So this patient's presentation with increased thirst, frequent urination, and unintentional weight loss is suggestive of diabetes mellitus. Now, elevated fasting blood glucose levels and an HbA1c of 7.8% confirms the diagnosis. Now, to determine the primary mechanism responsible for the elevated blood glucose levels in this patient, we need to consider the pathophysiology of diabetes mellitus. Now, in diabetes mellitus, there are two major types, as you all know, type 1 and type 2. The clinical features and the lack of information about autoimmune markers in this case suggest a type 2 diabetes mellitus. In type 2 diabetes, the most common underlying mechanism is insulin resistance, particularly in peripheral tissues such as skeletal muscle and adipose tissue. This means that the patient's body is less responsive to the effects of insulin, leading to the reduced glucose uptake in these tissues. The resultant impairment in the glucose utilization by skeletal muscle is a central feature of type 2 diabetes mellitus. Now let's talk something about the insulin and the diabetes mellitus and the insulin and, regulation and all. Okay, so the pre-proinsulin is synthesized in the rough endoplasmic reticulum of pancreatic beta cells. Okay, and then there is the cleavage of the pre-signal. Okay, then this cleavage of the pre-proinsulin, which leads to the release of proinsulin, which is then stored in the secretory granules. And whenever there is a signals, or whenever there is the mechanism which we are going to discuss next, there is the cleavage of proinsulin and there is the exocytosis of insulin and C-peptide equally. So both insulin and C-peptide are released in endogenous insulin secretion. For example, type 2 diabetes mellitus, insulin secretagogues or insulinoma, whereas exogenous insulin will lack C-peptide. So whenever a question if you encounter a question which says that the patient's insulin level is increased, but there is normal C-peptide level, then you need to think that the patient is taking exogenous insulin. Or whenever you encounter a question that the question says that there is both increased in insulin and C-peptide, then you need to think about some other causes like insulinoma. Now, insulin is synthesized in pancreas and cleared by both liver and kidneys. Now let's talk about the very important mechanism, that is insulin release. So whenever there is a glucose uptake by the glucose transporter 2 inside the pancreatic beta cell, then this glucose undergoes metabolism, which forms the glucose 6-phosphate. And this glucose 6-phosphate undergoes the glycolysis, citric acid cycle, and oxidative phosphorylation to produce ATP. Now, whenever ATP is produced, the concentration or the level of ATP inside the pancreatic beta cells is increased, and then the ATP dependent or ATP gated potassium channels, then they block. Okay, now when these potassium channels get blocked, then there is opening of the calcium channels. Okay, then when there is opening of the calcium channel, then this calcium will lead to the release of the insulin granules, and then these insulin granules will then just go and release the insulin. Okay, not so hard and fast rule. Okay, nothing so much uh, rocket science here. Okay, just a simple ATP gated potassium channel closing and calcium channel opening. You need to remember which channel closes, which channel opens. Now, in pancreatic beta cells, the glucose release requires calcium influx. Okay. Now the low blood, if there is low blood glucose, then there is decreased ATP, right? Decreased ATP equals to the increased potassium influx, because the ATP channel will not be closed, which will lead to the hyperpolarization, and there will be the decreased calcium influx. If there is decreased calcium influx, then there will be decreased insulin secretion. In case of elevated blood glucose, there is increased ATP and there is decreased potassium influx, okay? And that will lead to the increased levels of insulin. That is how the insulin or the blood sugar level is maintained. Okay, initially even the patients who are impending diabetes mellitus will have a normoglycemia because of this mechanism. Now let's talk about the insulin functions. Okay, now insulin acts in the brain and then it increases the hunger, it decreases the hepatic glucose production and decreases the lipoprotein production. Decreases the glucose synthesis and increases the glucose storage by the increased glycogen synthesis. It increases the lipid accumulation and it increases the inflammation. It acts on the adipose tissue too, where it increases the lipogenesis and decreases the lipolysis. It acts on the peripheral muscle, where it increases the glucose metabolism, increased glycogen synthesis, increased muscle mass, and increased mitochondrial dysfunction. So whenever there is a decreased insulin, or whenever the insulin cannot act on the peripheral muscle due to the insulin resistance, then there is decreased glucose metabolism because of the decreased glucose uptake, which will lead to the increased glucose blood levels. Now let's talk about insulin receptors. So there are insulin dependent and insulin independent receptors, transporters or receptors. Now, GLUT4 is insulin dependent glucose transporter, which is called which is present in the adipose tissue and the striated muscle. Okay, insulin independent receptors, whereas GLUT1, 2, 3, and 5, because 4 is already gone. 1, 2, 3, and 5 are insulin independent sort of transporters, which are RBCs, brain, cornea, and placenta. GLUT2 is a bidirectional, which is present in the beta islet cells, liver, kidney, GI tract. And GLUT3 is present in the brain and placenta. GLUT5 is present in the spermatocytes, GI tract. SGLT1 and SGLT2 is a sodium glucose co-transporter, which are present in the kidney and the small intestine. The thing that is important in this slide is the transporters GLUT2 and GLUT1. Okay, these are typically high yield, and actually everything here is high yield, but these are the most high yield in this slide, and these are asked most frequently, which is present in brain or which is present in the RBC and all. So brain prefers glucose but may use ketone bodies during starvation. RBCs utilize only glucose as the lack mitochondria for aerobic metabolism. Now, unlike glucose, insulin does not cross the placenta, and in mothers with diabetes, excess glucose can cross the placenta and it will increase the fetal insulin. That is the mechanism behind the neonatal hypoglycemia. Now let's talk about insulin regulation. Okay. Now there's insulin dependent glucose uptake and insulin secretion by pancreatic beta cells, which I've already discussed. But let's talk about now insulin dependent glucose uptake. Whenever there is insulin entry inside the cell, then it goes into tyrosine phosphorylation. And when it goes into tyrosine phosphorylation, the vesicles containing the GLUT4 are stimulated, and then these GLUT4 are transported towards the membrane, and then they act as a channel to entry of the glucose. Now this glucose will get into inside the cell. Okay. Now this glucose will go on to the glycogen, the lipid protein synthesis, and all. So this is how insulin leads to the uptake of the glucose. Also, the glucose will be leading to the release of the insulin, which we have already discussed, that will be happening in the pancreatic beta cells. So here, let's talk about the text that I have written. Glucose is the major regulator of insulin release. Now, insulin responds with oral versus IV glucose due to the incretins. Example, GLP-1, glucose-independent insulin polypeptide, which are released after meals, and beta cell sensitivity to glucose. Okay, these are all these text preferences are released by alpha-2. Okay, beta-2 and all stimulation. This is not so important, but what you need to know is that glucose releases insulin, and insulin leads to uptake of the glucose. That is how insulin is all regulated. Okay, if there is more glucose, there will be more release of the insulin, and then this insulin will lead to the more uptake of the glucose in the peripheral skeletal muscles and all, and then the glucose level and the insulin level will be regulated just like that. Now let's talk about a little bit about the pathogenesis of the diabetes mellitus type 2, actually about the insulin resistance. So if there is any unhealthy lifestyle like overeating, obesity, or inactivity that will lead to the intraperitoneal cavity accumulation of visceral fat, okay, now it will lead to the inflammatory mediators, adipokines, and free fatty acids increased. And there is complex unclear access on the body tissues. Actually, it is said that these fat, actually, free fatty acids go and block the insulin receptors. It is just a hypothesis, not so proved, but it is one of the most accepted ones. And then when these free fatty acids block the insulin receptors, that will lead to insulin resistance. And you can see when there is insulin resistance, then initially the beta cells of the pancreas work over time to increase the insulin. Now, due to this, the blood glucose is kept normal initially. Now, over many years, as insulin resistance worsens, beta cells tire out. That is, there is the decreased insulin secretion, and that will lead to the relative insulin deficiency, leading to hyperglycemia. So you need to focus some things, that is insulin resistance mechanism. Initially, the blood glucose is kept normal. After that, there is relative insulin deficiency, and there is hyperglycemia. Okay, now over many years, beta cells, they all get damaged until they finally stop producing insulin, and that will lead to the absolute insulin defect, and that will lead to type 2 diabetes mellitus. Right? So initially insulin resistance, but there is glucose level normal, and then there is a hyperglycemia. Now, this hyperglycemia stage is not diabetes mellitus stage. This is a state of relative insulin deficiency. And after relative insulin deficiency, when there is absolute insulin deficiency, then only there is type 2 diabetes mellitus. So let's erase this all. So I hope you all understood this one. So we will be again back in the next video with another super duper concept. Thank you for watching.